everyone. My name is Ipsita Banerjee, and I'm the ACT National Training Coordinator. Thank you so much for joining us for our June webinar as part of the ACT Consortium webinar series. Today's webinar is entitled Trials and Tribulations, Busting Myths in Patient Engagement, and will be presented by ACT's Patient Engagement Committee. Today's webinar is in a different format. It's a panel discussion, which will run over about 45 minutes, and we'll also have a 10-minute Q&A at the end of the session. We encourage you to submit your questions throughout the presentation, and we'll try to get to as many of them as we can in the chat box. So please use the chat feature for that, as well as during the Q&A session. Please note that today's webinar will be recorded. The Accelerating Clinical Trials Consortium is a CIHR funded program through the Clinical Trials Fund and was established to facilitate, optimize, and accelerate the conduct, implementation, and results translation from high-quality, high-impact randomized control trials to improve health in Canada and around the world. ACT's governance model is composed of 22 committees and working groups, and today's webinar is brought to you by ACT's Training Committee. The ACT Coordination Centre is located at PHRI, the Population Health Research Institute in Hamilton, Ontario, and therefore we wish to recognize and acknowledge that we are located on the traditional territories of the Mississauga and Haudenosaunee Nations and within the lands protected by the Dish with One Spoon Wampum Agreement. This agreement was created to bind the nations of the Haudenosaunee Confederacy to the Great Law of Peace. The dish represents the shared land, while One Spoon reinforces the idea of sharing in peace. We hope to bring a similar spirit of collaboration to the work being done by the Canada-wide members of the ACT Consortium. Today's panel discussion will be moderated by Dr. Ada Tang, one of the members of our Patient Engagement Committee. Dr. Ada Tang is a physical therapist, associate professor, and assistant dean of rehabilitation science at McMaster University. Dr. Tang and the Max Stroke Canada research team are focused on the impact of exercise on cardiovascular health, fitness, and function in people living with stroke. She incorporates considerations of sex, gender, and other variables related to recovery after stroke, always with a focus on equity, diversity, and inclusion, along with environmental sustainability. Dr. Tang received a YWCA Women of Distinction in recognition of her work, and was previous clinician scientist phase 1 and 2 with the Ontario Heart and Stroke Foundation. And with that, I'll turn it over to Dr. Tang to introduce our panelists and get the session started.
Thank you very kindly, Ipsita. Welcome everyone to today's webinar. Have you ever wanted to know more about patient engagement, but were afraid to ask? Have you ever heard some urban legends of patient engagement and you weren't sure if they were truth or just fake news? Well, you've come to the right place. In today's webinar, Trials and Tribulations and Busting Myths in Patient Engagement is a joint effort by the members of the Patient Engagement Committee of ACT Canada. And the committee has the goal of promoting patient engagement in clinical trials by establishing best practices for patient engagement, to determine barriers and gaps in patient engagement, and to support ACT members in their patient engagement within clinical trials. So today's webinar is meant for everyone, no matter how far along you are in your journey of patient engagement. You may be very seasoned and well experienced, to people who are just starting to think about patient engagement and maybe just taking their first steps. You are all welcome here, and we hope to get you off on the right foot or to help you continue along your journey, whatever that might look like for you. So today we're going to bust some myths. We're going to help hopefully demystify some of the perceived challenges and barriers to patient engagement. And we have a number of speakers today, as shown by the slide here. Our speakers are members of the Patient Engagement Committee, and we're patching in from coast to coast. And we have members who are a mix of patient partners and network manager and researchers. Before I turn it over to our first speaker, Dr. Stuart Nichols, I just have a couple of housekeeping items. As Ipsita was mentioning, we will take questions in the chat box, and you can feel free to put them in anytime throughout the presentation. We will take questions at the end. The intention is to support today to support ACT members in their patient engagement. So we want to make sure that this is a safe space for you to ask questions. There are no bad questions, and this is a judgment-free zone. Myths are meant not to make anybody feel bad, but they're here to start a conversation. So we hope to achieve that with everyone's help. And with that, I'd like to turn it over to our first speaker, Stuart.
Great. Thank you. So before we sort of get into the myth busting, we just want to go over a few terms that we need to be all consistently clear on. And the first one is just to talk about the term patient engagement. So you'll often hear about the words patient engagement in the Canadian context, but if you look to the literature and elsewhere, you might hear terms such as patient and public involvement and engagement. Those are terms more common in Europe and the UK particularly. But you might also hear about consumer engagement. That's the language used more in Australia. For the purposes of the presentation today, we're going to use these terms to mean the same thing. We're talking about active engagement with patient partners. Similarly, we also recognize the term patient has various connotations, but we'll be taking our lead from the CHR Strategy for Patient-Oriented Research, which defines the word patient as an overarching term inclusive of individuals with personal experience of a health issue, as well as informal caregivers, family, and friends. Now, recognizing that the term patient might be carry some stigma, but also doesn't apply in many contexts, you might also see language such as person with lived experience, or the acronym PWLE or PLEX. You may also see the term people with lived or living experience. Again, for the purposes of the presentation today, these will be used interchangeably. Next slide, please. And so I mentioned patient engagement. What do we mean by patient engagement in clinical trials? Well, it's really centered on this active collaboration between patients, researchers, healthcare providers, and other interest holders. And so it's about working together to create, to design, conduct clinical trials. And so really, we're focused on patients as partners. What we're not going to be talking about today are patients as participants in clinical trials. And that's going to be our frame of reference going forward for the rest of the talks. Next slide, please. So why are we interested in? What's the motivation for this? Well, if we want to track the sort of history in Canada, we can go back to the development of the strategy for patient-oriented research, where they explicitly called out two key motivators, and these really tie into some of the broader motivations for patient engagement. The first example talks about the disconnect between trials with a focus on drug development as opposed to other forms of interventions that might be more relevant to patients and families. And this really taps into this sort of more what we might call intrinsic or moral or sort of ethical dimension, where those who are affected by something have a say in the decision-making or actually shape the research that's being done. The second quote, which talks about the endpoint, so selection of endpoints, so that might be things like surrogate biomarkers and those sorts of things, as opposed to outcomes that really matter to patients or families. And this is more what we might think of instrumental or practical reasoning. So really it's about improving the quality of the research that's done, the relevance of the research that's done, and making sure that that hopefully is more salient to families and patients. But ultimately, we also hope that that might improve the translation of research into practice. So again, there's very much a sort of more practical lens. So these were the two key drivers really within the development of the SPORE framework as it relates to clinical trials. Next slide, please. And as we've got this investment in patient engagement in Canada, you'll see that we've also got increased infrastructure to support patient engagement in clinical trials. Now, some of these entities, such as the SPORE support units or the SPORE disease networks, are not clearly trial specific, but they do work to support patient engagement in clinical trials and have developed many resources. But we also now have dedicated infrastructure to support patient engagement in clinical trials. And this includes the recently funded clinical trial training platforms, such as CanTrain and the others listed here, as well as ACT itself, which has this remit to support patient engagement as Ada laid out. Next slide, please. Yet, despite this investment and the motivation, when we look to the literature, we still often see underreporting or a lack of patient engagement in reported clinical trials. Now, these are not Canadian examples, but I think it's fair to say that Canada isn't an exemption to this. So by understanding and actually busting the myths, we may actually help improve patient engagement in clinical trials, and that's our goal today. Next slide, please. So we're going to go into the myths now, and I'm going to hand over to my colleague and experienced patient partner, Maureen Smith, who's going to go through our first myth. Maureen, over to you.
Well, Stuart, welcome everyone. So I'm going to tackle the first myth, which is that clinical trials are too complicated for patients to be meaningfully engaged as partners. And I put in a couple of things there. So first of all, and I'll give a concrete example on the development of core outcome sets, which are complex. So some people believe that it's too difficult to explain clinical trials and research methodology. And on the third one, the false part is that so some people do believe that it is possible, but not for youth. And then they think that if we just do caregiver engagement, that'll include the youth perspective. And of course, that's false also. So it really is not too difficult. It just takes some work. And then if you're thinking about youth engagement, I put two specific concerns that are important for you to consider when you are engaging with youth. And I'm going to go on to the next slide and talk concretely about core outcome sets. And so I've been involved in the co-development of 6 core outcome sets in pediatrics now. So I think I can say with certainty that you can get meaningful patient and family engagement. We managed to do that. It's very important that we understand that, with core outcome sets, you're looking at Delphi studies, you're looking at consensus workshops. So it really is, maybe it could be the first time that someone has actually participated in that kind of thing, and that it's absolutely doable to explain all of those terms and all of those processes in lay terms and get meaningful engagement with youth and with parents and families and patients, and reaching those core outcome sets, as we know, if you're clinical trialists, are so important. So that agreed standardized set of outcomes that should be measured and reported in all clinical trials of a specific condition. If we don't include the voices, the perspectives of patients and their caregivers, then those outcomes may not align with their priorities. So it's really important, if you're going to do that work, that you then engage with patient partners so that you can get those voices, and they will advise you on how to present the materials, such as the definition of the outcomes and how to set up a patient-friendly Delphi survey, how to recruit and get participation in consensus meetings to include those patient perspectives. They're the best position to tell you, if you send me this Delphi, I can't do it because I don't understand it. So the biggest impact of getting those patient perspectives in Delphi is really on the inclusion of life impact outcomes. And I put the stats there for you because you clinicians love, researchers love stats. So really a big increase when you have patient perspectives in life impact outcome, and that's across all of the individual domains in those core outcome sets. And it also, the input also does seem to have an impact on the inclusion of adverse events, mortality, or physiological outcomes. So there on the next slide, on the last slide that Stuart will present, there'll be some resources that are available for you that are there's all kinds of resources for core outcome sets, but the ones that I've highlighted are for the ones if you're going to do patient engagement in core outcome sets. So I hope that you'll go over to the COMET website and look at POPI, which is the Patient and Public Involvement Group that I'm a member of, and take a look at some of the resources that we've developed on that. So that's a really important myth to bust, because the consequences of not including those patient perspectives and core outcome sets are pretty important. So over to you, Stuart.
So again, I think we just want to sort of counter the myth by saying, okay, so who is better placed to understand the impacts and realities of a condition or the accessing healthcare than patient families and caregivers, if the idea is it's too complex? And this is just a sample of the literature to show that we have lots of evidence about that instrumental impact that patients and families have on research. And I'll just highlight the bottom study here, which is a systematic review. It's one of several reviews now that show clearly for recruitment that patient and public involvement, as it was reported because it's a UK paper, has a significant impact in improving recruitment into clinical trials. So this is just some evidence to demonstrate the impact and show that addressing the issues that Maureen talked about really can improve clinical trials. Next slide, please. And then as Maureen alluded to, there's just a couple of resources there, whether it's identifying research questions or tools to help you think through some of the potential challenges to recruitment and retention in your trial. So I'll hand over to Alicia and Arlene now for the second bit. Thank you.
Thanks, Stuart. Hi, so we're going to talk to you a little briefly about our second myth, which is that only the patients need a training. So next slide. While it's true that, people with lived experience are, usually not medical or clinical research people, that doesn't mean that they're the only ones that need the training. The researchers, obviously, you guys have been trained in clinical trials and how to develop and how to determine the hypotheses and outcomes that are required in order to, get the information that you need, but not how to engage with the patient partners or people with lived experience. And it's one thing to invite patient partners to come onto your team, and if you're excited and you want to try this, but you have to know how and you have to think ahead of time, how are you going to include their feedback? Are you going to include their feedback? Are you willing to make certain changes in your proposal? Because if you're not, then it's not true patient engagement. It's definitely tokenism. And anything that cannot be revised due to budget or time constraints, or even constraints put on by what the funding agency says needs to be within the proposal, that all needs to be laid out at the beginning so people have a clear understanding of what they're trying to do and what can and cannot be revised. And while this kind of training does seem like it's primarily like soft skills and communication, it's really important to have that groundwork if you want to recruit and maintain or retain patient partners into your project. And so for the next slide, I'm going to hand it over to Arlene Desjardins, my patient partner and friend. Oh, you're muted, Arlene.
Good morning, everyone. I'm here to talk about, to give you a positive and a negative example of how patient engagement really does count in the research world. So we're going to talk today about how there was changes made to the kidney check research program. Changes to the kidney check trial is an example of listening to patient partners and incorporating our feedback. With the initial idea was a cluster randomized trial with each nation being a separate site. The Indigenous patient partner spoke up and said, that's not how we want to do things. We do not want to receive early detection and screening while other nations do not, especially early detection. This could make all the difference in the world during your kidney journey. Researchers listened and revised the trial so that every nation that would like to participate could receive the screening. This is an example of listening to patient partners' feedback and incorporating it into the proposal. The research team could have not listened, but then said, this is the way we need to do the trial to get the results. And instead they made the changes. That made all the difference in the world for the kidney check program. The researchers actually took the time to listen to what we were asking for and made the changes to their proposals. So that came out to be a very positive result, and we see that every day in the kidney check program with things that are happening with it. The other one is more negative. The negative portion is we had a patient partner that spoke up and said, engaging patients in an early, he was involved in an early priority setting proposal and development of a research project, but then got ghosted. He reached out to this group that he was part of, and he said, patient partner that was involved, he hadn't heard anything from him in 2 months. And when he emailed the project lead, he was told that the project had stalled and the RUB approval phase had been stalled in the RUB approval phase. This is an example of not recognizing the importance of a patient partner as a full team member. All the research staff were aware of the delay and working on other items while the REB process dragged on, but no one thought to inform the patient partner or the team members. That's a complete negative. That's a failure. You know, we have just as much to contribute as a researcher. You know, these are our everyday lives, and we don't claim to be highly educated in the fields that you are studying in, but we have everyday practical life experience. So we have much to give. So on the one hand, we had one project that completely changed their trajectory of their research, to the other project who completely ignored and showed that the patient partner was only there to be a tokenistic score on the piece of paper that they needed to make. So that can happen in our world. So our take-home message is that researchers need training and support to work with people with lived experience, and the patient engagement committee is working very hard to support this and to make change. You know, you can't do research with us without us, is what patient partners' perspective is on this.
So thank you, and I'll pass it over to Atto for the next myth.
Thank you. Hi, everyone. I'm going to talk about the myth 3, that patient engagement is just inviting people with lived experience to the table. Next slide, please. So I think it's important to talk about this terminology in order to understand the myth number 3. It clearly clarifies what the confusion is. I believe many people confuse with the terminology patient partner, patient participant, patient engagement, what that means. As we know, the previous speakers has already talked what patient engagement is. Again, I will talk one by one to those definitions. So patient partner is an equal partner on a research team whose valued lived experience and expertise can inform and advise at all stages of a research cycle. However, a patient participant is they're just invited for to provide their shared experience or to share their experience to the research team. Next slide, please. And what is patient engagement? Patient engagement occurs when patients meaningfully and actively collaborate in the governance, priority setting, and conduct of research. And why patient engagement is important is, I think, the previous speakers already mentioned it, but I will try to explain on the ethical perspective. So a meaningful patient engagement grounds research in a deep understanding of the health situations and the living or lived experience of actual patients, including groups that are typically underrepresented in research, and to make research more relevant and usable by those patients. So what does this mean is to have equity or inclusion. Like Canada is a very rich country in terms of diversity. There are a number of people migrated, or even in Canada from different diversity. So if we are to make the research more inclusive, or like to increase the credibility of the research, I think engaging the patient is very important. To promote research methods that are culturally safe, respectful, and appropriate, and to legitimize research in the eyes of the community that the research is intended to benefit. So again, this means like the patient partners are kind of bridging, like connecting researchers or clinicians to the community. They're trying to connect, try to narrow the knowledge gap and to improve the understanding of the communities in terms of the research. Because the goal of the research at the end of the day is to improve the healthcare, to have an equitable, sustainable, and accessible healthcare. Next slide, please. And the level of engagement could vary depending on the capacity of the patient partners. They could be as simple as leading the interviews in terms of the collecting data, or they can be like designers, or they can collaborate in implementation, co-authorship, and so on. Again, this varies from the patient partner to patient partner, and their contribution varies with their skills and the experience they have. Next slide. So that's the typical stage of research. I'm just talking generally in a research, whether it is qualitative, quantitative, the clinical research, but it starts with the priority setting and the planning. That's the problem. Developing of research proposals, scientific review, ethics review, oversight of a research project, recruitment of research participants, data collection and data analysis, knowledge exchange and translation. So why I brought those cycle is patient partners could involve either at some level of those cycles, or they can engage at all levels, again, depending on the capacity or the skills and the experience that they have. That the importance of like prioritizing, setting, or planning is like if it is a patient identified problem or research, that's how the outcome also match or helps, can fulfill the needs of the community. Next slide. Okay, I will pass to the next speaker then.
Thanks, Atto. So there is an increasing expectation that research teams include knowledge users, and in particular, partners with lived and living experience as part of the research team. So can partners with lived experience actually be principal or co-principal investigators? So I'm exploring the myth that they cannot, but indeed they can. Thanks. So there's a variety of requirements as a co-principal investigator. They can complete either the common CV for those who have an academic background, but more often they can instead complete the applicant profile CV. They need to register with a CIHR PIN number, complete the Equity, Diversity, Inclusion Self-Identification Questionnaire, get a certificate of completion of the sex and gender module, complete a paragraph highlighting 5 most important or most significant contributions that they've made that are relevant to the grant, and define their indigeneity if appropriate. So in terms of the applicant profile CV, what this includes is a personal statement of how they would contribute to the research project, what would be their roles and responsibilities, and how this relates to their lived experience. And then, if relevant, if they have particular positions, awards, have participated in creating knowledge as part of other research teams, or have been involved in knowledge exchange or other relevant information that relates to the project or grant, team grant, this is an opportunity to include that in their applicant profile. They can also highlight up to 5 significant contributions that can relate to publications, knowledge translation activities, any training that they've done, if they have relevant credentials to the project, if they've been involved in community engagement or clinical practice in some ways. So it's for them to decide what aspects of their experiences can be relevant and will contribute meaningfully to the research that's being applied for. Next. Having said that, each of these elements can be very challenging for people to complete, particularly if they're not from an academic environment, which, you know, if you have a diverse group of patient partners or partners with lived experience, they're unlikely to be familiar with many of these different requirements. So this is just a quote from a parent partner at Childbright after doing the sex and gender module. I really struggled with this training. It is really not meant for someone who has no knowledge of medicine and high-level research ethics issues. I have very good knowledge of sex and gender, but in this context, it was difficult because it relied on your understanding that these concepts and how they relate to certain medical conditions, it was quite difficult to complete. So this is something to really challenged the SPORE network and the SPORE leadership in CIHR to come up with a module that is more appropriate for different knowledge users. Next. So in summary, partners with lived experience can be co-PIs or principal investigators in CIHR applications, but it is challenging for them. They often struggle with many aspects of the requirements. The sex and gender module, as I just said, even just, getting a PIN number, knowing how to navigate the portal is not that simple. Also coming up with the applicant profile and the significant contributions, they're not really sure what is relevant. So we have found in Childbright, when we've had co-PIs who were co-leads of programs or youth advisors, Indigenous advisors, so they played very important roles in the network, is we had them work together with a research coordinator and do all these elements with support. And this greatly enhanced their ability to do these activities without feeling any stress or pressure around them. So just having a conversation about their contributions then enabled them to kind of tease out what might be important to put down with help. So I just want to also highlight that Maureen Smith has a guide to help partners with lived experience in the completion of these requirements. So that will be available on the website. It'll be important that if you're applying to another agency, another funding agency aside from CHR, to verify what their criteria are, what they are required for partners with lived experience, because different agencies will have different requirements. And now I pass it on to Amanda.
Thank you, Annette. I was tasked with tackling the myth patient partners are offended by compensation. And I'll point you to the reference on the screen, which was actually written by patient partners, patient partner compensation, research and healthcare, the patient perspective on the why and the how. Next slide, please. While some choose, first, I actually have to say that compensation is not reimbursement. It's not reimbursing costs for flights or childcare or other travel costs and stuff, but it does recognize patient partners' time, skills, and expertise. And there are indeed some patient partners that choose to volunteer and have the means to do so. There are many, many reasons to compensate patient partners. Imagine you're a part of a team, you're all supposed to have equal footing, but two of you aren't getting paid or recognized in some way. How would you feel? Everyone else on the team, everyone else on the team will have some form of compensation or recognition based on their skills and expertise, except the patient partners, unless they're compensated or recognized in some way. We all have different motivations. If you're a researcher, you're building your portfolio, you're building your CV to apply for grants. It's beneficial for you to have grants and such. It's kind of academic credentials, and it actually goes to the ability to have future earnings. Patient partners aren't going to get that benefit professionally. They may if they do have an academic background, but typically if they do not, they would not get that recognition, and they would have different motivations. Respect for vulnerability. I was speaking about patient engagement to a group of perinatal clinicians, and it set me back 20 years to when my second child was born, and I woke up to them not being in my room, to them being observed with tubes coming out of them and trying to deal with that and such. And even though I thought I had been over it, because I was speaking about it and thinking about the type of patient partners that these particular trainees would want to partner with, it set me right back into that space. We have a lot of experiences that aren't so positive in healthcare that interacting with research teams may bring up memories that aren't great. We do have some positive experiences as well, but we bring our vulnerability as patient partners, and that needs to be respected. Commitment. Some people do volunteer, as I mentioned earlier,
and that's their choice. Some of us still have caregiving responsibilities. We have jobs outside the home as well. We're doing other things, other volunteer commitments. We have to juggle medical appointments or dealing with the education system, advocacy. Sometimes having that compensation helps to further the commitment. It also helps in my family for my kids to understand why I'm doing something as opposed to doing something with them at any particular time. And imagine if you were somebody that needed to have a second job to put food on the table, or had a different situation where there were barriers to being a patient partner. That compensation does help. It removes that barrier of being worried about that extra money that you might have to make just to meet the needs of your family. It conveys respect. It suggests that you value patient partners. And also I found a paper that suggested that there's actually more trust in the research if you compensate your patient partners. In short, the option of compensation helps to foster meaningful engagement. But when you think of compensation, what do you think of, and what do you think of the logistics? How do you think of the logistics around it? There's a lot of different considerations. One are our own assumptions, whether we're patient partners or researchers. We might have a bias against what is actually should be compensated for. Is it that education that we got at the post-secondary level, or is it the skills and the knowledge that we've obtained through living our lives? There may be institutional policies and procedures that are complicated or unknown. There may not be one in place depending on where you're doing research at, or there may be things that need to be set up in a way that make it easier for patient partners to get compensated. We need to think about flexibility, and this will be, depending on what the patient needs or the partner needs. It could be, is it a per project compensation? Is it per hour? Is it a gift card? Is it an e-transfer? Is it something that's put in your bank account, a direct deposit? Is it another form? I had the opportunity to give feedback on a compensation policy or terms of reference for a group I'm in lately, and they offered cash. And I was like, why would you offer cash? And then last week I heard about partnering with unhoused people. And the comment was said, it's better to offer cash in this case, in-person engagement, because if they are offered gift cards, it's assumed they stole them. Think about the stigma attached to that. So all of those, the form might depend on the person partnering, and the timing. Sometimes the timing, it can be for planning purposes, it's great for us to know the timing, but it also can affect things like reportable income and such. And that comes to income. Are there situations where getting compensated might impact income you're already getting, whether it's from workers' compensation, disability, parental benefits, or others? And what tax implications are there? Every organization, if you, as a patient partner, are compensated more than $500 a year, a T4A is required. Do your patient partners know that? There's privacy considerations. As I said, that's very individual as to how you would compensate a patient partner. Those conversations should be done on an individual basis. So if you have 6 patient partners on a project, you should be having 6 different conversations. But even another case happened to me lately when I was submitting a document to get compensated, and the particular university wanted my name. I was required to give my birth date, and they asked for my social insurance number on the same form, and they asked for me to email it back to them. Now, in the past, if somebody wants my social insurance number, I've been able to call or I've been able to text, which is actually more secure than email. And I was not comfortable sharing all of that information about myself over something that's not necessarily safe. Budget. Have you budgeted already? We've talked about, do you have the funding? You may already have received a grant that you didn't get funding for patient partnership. And that brings us to those clear communication pieces that were spoken about earlier. This can be a barrier, but it also can be an opportunity to clearly communicate that to your patient partners and to recognize them in other ways. And so that could be a lot of different things. You can recognize a simple thank you can go very far. circling back around and talking to the patient partners about how the project was impacted. It could be co-authorship, access to training opportunities. Your group might have a group training opportunity that adding one more person may not cost you, but might actually mean a lot to that patient partner to gain new skills that they're interested in. Or it might be team building activities. And I can't really see myself here, but one of the first projects I was on, we all got hoodies that had the project name on it. And all of the members of the team talk about making you feel part of the team. It wasn't a big cost, but it communicated lots. Next slide, please. So in short, the take-home message is patient partners are not offended by the offer of compensation, but should have a choice in how they are compensated and are recognized. And I'm just reiterating, budget from the beginning, know your procedures, and initiate those conversations. Although I didn't say you should be the one to initiate those, with the power imbalances that are already there, researchers should initiate this conversation. And there's a reference here that gives a nice little figure on what you need to be prepared for with these conversations. And I'll hand it over to Ada.
Thank you so much. Thank you to all of our panelists today for busting these myths. We started off this afternoon with some key definitions just to lay some groundwork, and then these are the 5 myths that we busted. Clinical trials are not too complicated for patients to be meaningfully engaged. It's not only the patients who need the training. Partners with lived experience can be PIs or co-PIs on CIHR grants. Patient engagement is not just about inviting people with lived experience to the table, and patient partners should be offered the opportunity to for compensation, that it should be an option available to them. So on the next slide, we share there's a number of resources that are available online to help guide people along the patient engagement journey. This is one from CanChild that talks about the how, the when, and the why. And there are other resources available. The ACT Canada just had an earlier webinar with Dr. Kathy Craven talking about a patient engagement toolkit, and that recording is available on the ACT Canada website. So we invite you to watch that and access that toolkit as well. Just in closing, we wanted to share these myths and try to bust them in order to, as we said, demystify some of the maybe perceived challenges and barriers, and just to help get people off on the right foot. We are all on this journey together. We might be the patient engagement committee, but we all started somewhere. We all started with the first step, and we're all at different places along our journey, even amongst ourselves. So this is a community that we hope to continue to nurture and support through the committee and through ACT Canada. And hope that and thank everyone for their efforts to advance patient engagement within your clinical trials and within your networks. We hope that the information today it will be a start of a conversation for you as you continue on your work. So we do have time for question and answer. I see that there was a question that was popped into the Q&A that was addressed around developing a patient advisory board and how to pick networks, pick members to represent diversity. And that has been addressed by Stuart and Annette. So thank you very much for that. I also am looking at the Miro board, and there have been a couple of post-its on there, and I invite our audience, our participants today, to keep populating that Miro board as you think of things. But I will put out one of the questions to the group here. One is, how do you approach a patient within a trial about becoming a partner? How do you start that conversation?
I think there's different sort of mechanisms, and obviously there are things like the provincial sport support units that can provide support there in terms of that. But I think, part of it is having a clear, and again, it goes to the question that was put in the Q&A, what is their role? Is it your own patient? Again, we have to be aware of those power imbalances and the challenges there. But being clear about what you're going to ask them to be part of. Are they are they going to be advising or potentially partnering on the trial that they've already been involved with, for example, or are you approaching them for another project because they had some helpful feedback? Again, Maureen and I have spoken about that as a topic of, you know, people, particularly in the rare disease community, in terms of the issues that face there, in terms of the availability of trials to that community. So I think, you know, obviously it's a challenge to approach them when they're still in the middle of the trial, but I think often we build in questions at the end of trials to say, you know, would you be interested in other opportunities? That's something we often build in, but yeah, I think that those are all things we need to consider, and I don't know if Maureen wants to sort of follow up on that.
I'd love to add
Maureen.
something to that, Stuart. It's a really good question. And one of the conversations that researchers often have with patient partners is, you know, you give your time and you join a trial and you're a patient partner and you do a great job, and oh, there's another grant, or the trial's going to continue. They're going to get an additional grant to do another piece of the trial. I'm thinking, for example, in core outcome sets, oh, now we're going to develop we're going to get your feedback on the outcome measurement instruments. It's very, very important that when you provide the opportunity, that you make it very clear that what they signed up to do, they did, and you're grateful for that. And that if they want to continue, you're offering it, but it doesn't mean they're quitting. I've seen things like, if this is time for you to step off, not stepping off, the piece that they signed up for ended, and it kind of devalues. It's like if they don't continue, they're kind of letting you down. So just as it's really important to continue giving people opportunities and make it available for them, because they may be very invested now and they want to continue, it's really important not to devalue them if they decide that they had this 1 year to give, they've given it to you, and now they're going to move on and do something else. And I just feel really strong because I've seen that happen, and I've seen people like apologize for not being able to continue. And I just feel really badly. So your language when you're offering opportunities has to always be, if this is the end, you know, this is the end of this trial, if you'd like to join us or whatever, you're welcome to do so. We'd love to have you. But if this is where, you know, where we're parting for now, we're extremely grateful for everything you've done. So I think that conversation is as important as that beginning conversation that Stuart so eloquently talked about. Thanks.
Thank you, Maureen. I think that's a really important point to recognize people's contributions when a project is finished, and that's time limited, and now we might be moving on to something else and giving the opportunity to decline without any judgment or without any without any judgment. So thank you for sharing that. Annette also has something to add.
So I think, you know, when researchers are looking for partners, they have particular lived experiences that match the project. So they have some, you know, some requirements or whatever, and they may also be seeking more diversity in their patient partners. But I think once you're meeting with the individual or individuals, that there are clear roles and responsibilities, like the expectations are clear on both sides. So what we've done based on learning by experience and making mistakes is we've developed some tip sheets. So there's tip sheets for researchers and tip sheets for parents and for youth. So they were developed by our partners with lived experience in terms of what to discuss, like really the details of, you know, what the responsibilities might be, what are the communication preferences of the individual, what the compensation will be, what are the flexibility that's required, that, you know, people may not be able to attend or participate all through the research cycle. They may have to step away periodically because of, you know, things going on in their lives. So just having a sense of like the engagement strategies and being really transparent, and that it's really a two-sided conversation with responsibilities on both sides to enhance that authentic engagement. We've also had, so sometimes it's not a matter of recruiting by researchers looking for partners, but rather people that want to join the network and ask like, how can I contribute? So we do have like a matching tool where they complete a form of the ways that they might want to engage, some of the things that they can bring to the network in terms of either their lived experience or, you know, let's say they have communication skills or photography skills or whatever it is that they think might be helpful. And then we do our best to try to provide a match, basically, in terms of the different projects and programs that we have. So it can also come, like, and it be initiated by the partner as opposed to the researcher. So just to add something.
Annette, I really like your idea of the matching tool. So maybe people, the public who's out there might have something to offer, and the researchers, you know, don't necessarily have connections with them otherwise. How do you find getting the word of the matching tool out there and spreading the word so that people are aware that this is even opportunities that are available?
So we do use social media quite a bit, you know, through X and Facebook and LinkedIn now also. We find that those strategies are helpful in being broader in our approach. We also have we have an internal newsletter, but we also have a public-facing external newsletter. So that's open to anybody and provides all kinds of opportunities to engage with the network and to know about what we're up to and if there's training activities or different events that might be of interest to the public. So sometimes it's through that mechanism that people become interested and then reach out.
I think sometimes I find not everyone is active or you know, has access to social media. If maybe if any of the other panelists have other ways that they really try to extend their reach.
You know, as we were growing, we wanted to be more diverse, more people with different ethnic backgrounds, different geographic reach, rural settings. So we did a lot of like like people individually reaching out to others or through Facebook groups that people were aware of, you know, so the more like personalized approach, but with a deliberate audience that we're trying to more fathers, more youth, that type of thing. So that's also really important.
Identifying people maybe who aren't already represented and really trying to specifically target them. Sorry, Amanda.
For some groups, and this is not my personal experience. My personal experience is I tell everybody in my personal sphere about patient engagement if they seem to be interested. But there was a talk from the PXP hub, and one of the patient partners that was giving the talk is she got involved with patient engagement through the gym. And we talked about libraries and community spaces. So not everybody is on social media. And not everybody's going to be partnering in the virtual realm. So think about the networks that are in your community and around wherever you're doing research that maybe have the people with the demographic that you want to partner with. Reach out to them.
That's great, Amanda. Alicia has also shared a resource on kidneylink.ca that she pasted in the chat to share information about research participation and patient engagement for those with kidney affected by kidney disease across Canada. And lots of links coming in through the chat. So I wonder if there's a way that we can save all the resources in the chat that we can post along with this webinar, because I know it is being recorded, but the things that are in the chat and the great resources that are here, just to make sure that they won't get lost. And the other comment that was just in the Miro board as we wrap up today was around multilingual patient engagement opportunities. And I think, you know, we're touching on this a little bit about trying to expand our reach and trying to diversify representation of patient partners that, you know, to ensure that it's not just English centric, but to recognize that certainly in Canada, French language is the other official language of Canada, but certainly a lot of other ethnic groups will benefit from having materials in other languages available as well. Thank you. Annette is putting in, tips. These are the tip sheets for patient partners and tips for researchers. The PDFs are also in the chat. And I have confirmation from ACT Canada that we will save all these resources and share them amongst, everyone as well. I don't see any other questions coming through. Again, maybe just as a few minutes in closing before I hand it back over to IPSITA and ACT Canada, is that the Miro board, we will continue to keep that open, and you are welcome to populate that as you think of things even after we end today's call. We will certainly use this as a resource and kind of crowdsource information from the ACT members, which can help guide us, the patient engagement committee, within our activities that we will continue to do to help support our members. So that will still be available. And certainly we can be reached through ACT Canada if anyone wants to reach out to us directly beyond this.
Well, thank you so much. We, on behalf of ACT Canada and the training committee, we really, really appreciate all the time that our panelists have taken, and our moderator, of course, to present all of this information with our participants today. We hope you took a lot away from this, a lot of the questions from the myths or common questions that I get as a training coordinator. So I really appreciate all of the detailed information that you're able to provide. You provided lots of concrete examples and some really important process pieces that I think people get tripped up on quite often. So thank you for sharing so much detailed information. As Ada said, we will collect all of the information that was shared through the chat, through many of the questions that were asked. We'll collect all of those and share them with participants as well. So thank you all for joining us.